invite the
Thank you.
panelists over, Dr. Yankee, Dr. Croissants, Dr. Ferrugia, Dr. Rao, I think is downstairs, Dr. Shamas is here, and Dr. Tadros.
Yeah.
All right, we'll get started. So, you guys want to present?
Excellent. Sure. Thank you very much for the invitation. Let me introduce our team. Can we put the first slide? Okay, on my right side, I have Bill Gossi, who's one of our colleagues. We have our interventional fellow, Nicolas Diakos. We have our interventional radiology fellow, Usman Shahid. We have our CVT tech, Wen Ling. I'm sorry, can we put that music down? Okay, well, is that a phone or something? Okay, we have Lily Rogosic, our radiation tech. We have Rachel Askaria, sorry for my pronunciation. She's a registered nurse. And Minu Kachapali, a registered nurse as well. Next slide, please. So let me give you a little story of our patient. This is a 71-year-old gentleman with past medical history of hypertension, COPD, coronary disease, aortic stenosis status post TAVR, PAD status post left carotid endarterectomy, bilateral common iliac, left external iliac stent, as well as a right common femoral artery stent that was placed as a complication of the TAVR.
And 25
at that time, he was treated with shockwave lithotripsy in order to get the sheath up into the aorta. And while the surgeons were coming out, they tried to close what they had done a pre-closure, and that did not work. And they ended up having to put a cover stent on the right common iliac. And we'll show you some of those films. Past medical history, as I said before, social history is a current tobacco smoker, no E2H or drugs, medications, aspirin, beta blockers, ACE inhibitors, and statins, as well as cilostazol, which he did not tolerate, so we have to stop it. Physical examination, vital signs were unremarkable. Distal pulses were +1 on the right, +1 on the left. The right ABI was 0.85, and on the left was 0.81. Let me show you the films that we did a couple of weeks ago. Can we show the? Yeah. Correct, and I'm going to show that. Can we show the prior films? Can you guys see them?
Yeah, we see, but we don't see anything running. We just see still images.
Okay, can we see can we show the old films, please? I think you're showing the live films. Just bear with us a second.
Sure. So how long ago was the stent on the left external iliac and the right common femoral?
That was about 5 months ago.
5 months.
Mm-hmm. And as you see, well, you still cannot see, but I'll show you the underexpanded stents, and that's an issue that we're going to be working with. Guys, can you see the old films yet or not?
No, we cannot see anything. We just see a still image.
They cannot see the old films. Yeah, so we're not going to show the live. We're going to show the old films, and they cannot see it yet.
Yeah, the review station, guys. What? Okay. Yeah, and turn up the O2.
All right.
Okay.
Now, I want to see the old film, please.
Yeah, we're seeing some pictures now.
Yeah, that
was our scout shot for access.
That's from today.
Awesome.
Guys, can you show the other films? Guess they should put the music again, right?
So how's the distal runoff, the SFAs and below
it's
the knee?
not bad, actually. On the left side, you see there's a pop bypass. The left SFA was occluded. There's disease in the profunda, but there's 3 vessel runoff. And in the right, there's no FEMPOP bypass. Just want to show you. Okay.
Again.
Do you see this?
Yeah, we see this now.
Okay, good. So you see the bilateral common iliac stents. You see the right common femoral cover stent, and you see the left external iliac stent that is actually underexpanded. There's some disease inside of it. And on the past, they've tried to expand that, and there's elastic recoil, and The reason for that is what we think is some calcium behind it. So what we're going to do, we're going to do an IVUS, and you guys could help me analyze it. But I'm suspecting that there's calcium behind that stent and is enabling the stent to expand appropriately. This gentleman is going to have recurrent restenosis. So hopefully, what we'll do is do a peripheral lithotripsy, hopefully put then a covered stent, and then try to dilate it aggressively with non-compliant balloons. Can we show the next film, please?
What kind of stent is that on the left external iliac?
That's a live stent. It was placed 5 months ago.
What size was it?
The one in the external is an 80 by 60, I think it was.
So just to the panelists, whenever you see a
And then the
calcified
top,
iliac,
they're both 9 millimeters.
now the first thing which comes to mind is a perforation. So, and we often undersize or
Right.
oversize. So, how many of you guys go in IVUS directly to begin with? Even before you deploy the stent, you cross the lesion, do an IVUS.
I think IVUS is necessary for any lesion at this point. I don't believe that not fully evaluating both for circumferential calcium and this goes for the iliacs as well as your lower extremities. The added benefit of utilizing IVUS in every case is significant, both for sizing, for lesion complexity, and for severity of calcification.
And does it
I agree
help you?
completely with you guys.
So, Dr. Wiley, I'll let you work while we keep discussing, and then
Yeah,
we'll
so
get
let me
the
show you
first
the-
presentation. Yeah.
Let me show you the previous films. Can you go forward, please? We have a few different projections, and then we have the abdominal urogram with distal runoff, which is what you guys have asked before. Play it, please. It's another angulated view. Next one, please. You see there the fem-pop bypass.
And profundus.
Next one, please. Profundus disease, yes. That is the right, and you see there the common femoral cover stent. Next one, please. Next. One more. I think the next one is the runoff. Here we go. Okay, so you see disease in the right SFA, the left is occluded, the bypass graft is open. There's a short occlusion in the right distal SFA. Hops are okay, and there's reasonable distal runoff. I think it's 3 vessels actually coming down. Okay.
So I want to ask the panelists, how would each of you guys approach this? Dr. Krishnan, I'll start with you.
Yeah, actually, I was that exactly like it was said. There's probably a lot of calcium behind that narrowing there that has not been visualized originally on the angiogram. As we have seen from the previous case, you can look at an angiogram and you will think the calcium is mild or barely existent, and you look at an IVUS and it's just a completely 180-degree different conclusion. So I think you're going to see a lot of calcium there, but that's how I would start IVUS it, see exactly what you're dealing with, size it, and go from there.
Okay, so we have 2 IVUS machines here. We have the phase array and we have the rotational one. I know you have fellows in the course, so I have our young interventional staff, Yuhei Kobayashi, who has an area of expertise in intravascular imaging, giving us a little insight in terms of what IVUS to use and why.
So you want to show the slides first?
Please.
Okay,
Sure.
slides, please. Okay, so let me quickly summarize 2 types of IVUS. As you can see on the top, which is a rotational IVUS, which is by Boston Scientific or Philips Volcano creates, many companies creates these rotational IVUS. And then the one in the bottom is so-called phase array, which imaging core is not rotating, rather 64 imaging elements is mounted, and then that is going to create 360 degrees of circumferential imaging. So 2 major difference is essentially The rotational IBIS has higher frequency, typically 40 megahertz by Boston, or 60 megahertz by Boston, or 45 megahertz by Philips volcano. So these higher frequency, as opposed to phased array 20 megahertz, gives you detailed, beautiful pictures. But unfortunately, that is a trade-off with penetration. So higher the frequency, lower the penetration. But in the bottom, the 20 megahertz IBIS, which we are using, is less resolution, so less beautiful picture maybe, but it has more penetration. So which means it can be used in larger vessels. Go to the next slide, please. So this is, again, explaining about penetration. So then, if you can imagine the peripheral vascular disease, such as iliac intervention like this case, we might want to have a nice penetration. So that's why in this particular case, we are trying to use a phased array 20 megahertz IBIS. Go to the next slide, please. Yeah, so this is, again, the transducer selection. Larger transducers with lower frequencies are better for larger vessels, so you can sometimes use for aorta, but for the smaller vessels like maybe SFA or BTK, you might want to use a higher resolution but lower penetration device, such as 45 megahertz Philips volcano one.
Excellent, Yuhei. So I guess our trade-off will be less frequency for more penetration.
Exactly.
Can you guys put the IBIS up live?
So, Bianchi, what would you do?
I'm afraid of interrupting him. Very commanding.
No, it's okay.
All right. So before committing to the feeling of if you don't have IBIS, you cannot practice peripheral vascular interventions, let me assure you that we did do that with preoperative staging CT scan and the ability to predict calcification level, bleeding risk, etc. Definitely, you can tailor, you can be more accurate, you have more feedback intravascular ultrasound for many pathologies. So definitely, you should have one, but you can do these cases with intravascular ultrasound. Just as a word of caution there. The approach will be essentially the same. I think I agree with the mode of failure of the in-stent restenosis may be. Since it's only 5 months, it's probably a technical issue. I'm doubtful whether this team actually placed that stent. Maybe it was another team who placed the stent, and they may have settled for a residual stenosis because the burden of disease they treated was so much that looked at the time okay. And then the patient now realizes maybe he's claudicating on a larger distance, yet is disabling, and the failure of cilastasolol certainly grants the operation or the procedure. So, yeah, I think I will debulk it with intravascular lithotripsy and see balloon and see what happens.
Okay, so let's do a run of this IBIS, and then you guys can see the IBIS, so you give us your opinion. You guys seen it?
Yep.
Sure.
Okay, let's go.
Can you put it on the biggest screen actually?
Full screen, yeah.
Yeah, perfect.
You guys see it?
Yeah.
Okay, come on. I'm in the distal aorta. Going into the left common iliac stent. A16 stent struts. A little compression there. This seems to be okay. We go the space between the common and the external stent. There's calcium circumferentially, and now we're getting into the mouth of the external iliac stent. Then it opens up. So it's essentially in-segment restenosis what we're having. Okay. Okay.
Okay. So let me review the imaging. So this is the one we just obtained. So let me stop and scroll. So this is clearly the.
Sorry, go ahead.
Yeah, this is the
Yeah, he's going to size
proximal stent. As you can see, the stent is well expanded. It's like 8.4 by like 9. So that's the proximal stent. So we're just going more distally. As you can see, this is, calcified plaque, but this is a relatively preserved lumen size. And then, but as you can see, this is clearly a calcified vessel. And we are going into the proximal edge of the distal stent, C. As you can see here, the stent is like, eccentric expanded, like 7.4 by like 4.7 or something like that. This is primarily because you see the calcium behind the stent strut. It's like 12 o'clock to 3 or 4 o'clock. So that's primarily the reason of the failure of the stent. And I don't see too much neointimal hyperplasia within the stent. As you can see, stent struts can be clearly seen. So most likely this failure of this old stent is primarily due to the calcified plug behind the stent strut, which now makes sense to use shockwave balloon.
Last thing.
Well, let's get the shockwave.
So apart from helping us from the sizing of the vessel, is there any particular objective criteria with regards to calcification? Like, this will deal with a simple non-compliant PTA or due to lithotripsy? Because I often come up with a challenge. You look at the angio, I feel, this needs lithotripsy.
Well, the problem's behind the struts. So you've got to figure out what technology is going to help you get behind the struts to allow you to expand, because you don't see anything obstructing the lumen. So it's a compression problem from outside.
Yeah, still lithotripsy works just fine in that situation. We've tried several cases of underexpanded iliac stents with lithotripsy, and it really works okay. Even with the stent in place, it still modify quite a bit what's behind the stent, and it makes a big difference. So we'll see what would happen here.
So to follow up on that, do you think there's a difference between fully circumferential calcium burden versus just isolated on one side of the vessel?
I don't think so. I mean, I think your emitter is a 360-degree emission, so it should really hit pretty much everything.
And because the biggest size we have is a 7 millimeter, right?
Right.
And so here we're getting a 7x4. So, Dr. Wiley, are you going up with the 7 millimeter balloon or?
Yeah, it's the largest one we have available. And it goes through our 7 French sheath. For the fellows who are there and don't know how this technology works, there's electricity or electric energy that is delivered to the emitters. I don't know if you guys see the slide.
Yeah, we see.
And it causes vapor bubbles, which expanding and collapse, which is nothing more than those sonic pressure waves, which cause the expansion of the vessel. Essentially, you get approximately 50 atmospheres of pressure when we do this.
So, Christian, I have a question. I've got a question for you. So you brought up CT. I love CT
Can we get
as well.
line, please?
This is eccentric, right? So there's like a 90 to 100 degree arc of external calcium compressing the stent. There is, I'm not saying it's highly likely, but there's got to be some concern, and you would be able to see it better on CT if you go crazy expanding this. You're going to be pushing the calcium in one direction. It's not like you're yielding the whole artery. It's all going in one direction. So there is a chance that you could mess things up, right, and cause a perf.
In terms of peri-procedural complications?
Yes.
Absolutely.
Yeah. I mean, I think that's a point to be made. I mean, because we get so focused on we've got to expand the stent, but this thing's very eccentric, and all of the force is going to be going one direction.
And we're going back to the pathology they're treating, which is intermittent claudication, disabling or non-responsive to silastazole. And, when you have to make decisions about bleeding risk, cavitary bleeding risk, and distance for pain-free ambulation, I think it's a fairly straightforward stay on the side of non-bleeding complications. So all you need to do is improve the hemodynamics and
Exactly.
get your
perfection, your enemy.
absolutely get your physiologic baseline and just improve hemodynamics and exercise program really.
I think we have a question from the audience. Go ahead.
So it looks like all the calcified iliacs now are, people using lithotripsy very widely. What did you guys do before lithotripsy? Or if you don't have it in your lab?
Specialty balloons, and with varying degrees of success, and with covered stents nearby, because you would go to high pressure, and it wouldn't be completely uncommon to have a perf, and so you always had to be ready for that sort of situation. But this has helped. I mean, but it's not foolproof either. And I think what you're hearing here is that, I think you have to predetermine what's going to be good enough as a result. Because I think if you're hell bent on making that part of the stent look like the rest of it,
it's not plastic surgery here, guys. We're not looking at cosmetic outcomes, really.
This is where the old adage, the enemy of good is better.
So I've
use
used
0.5.
orbital
We could
atherectomy in
use
certain
0.5.
situations, where your
0.5.
vessels are very calcified and severely narrowed. Of course, if it's calcified and moderately diseased, orbital atherectomy is not going to do you much because the orbit itself is not going to even reach that calcium. So you have to have severe calcium, severe lesions. In that situation, it probably helps, and in fact, it does. We've done several cases like these, and it works just fine. The problem, however, is you don't affect the deep calcium, and the stent expansion still is not very good, and that typically what happens. So in some cases, combining even the technology can work extremely well. I don't think there's any data about orbital atherectomy plus stenting plus lithoplasty, then stenting versus just lithoplasty and stenting. So it'd be nice to know, what happened with that stent expansion. Are you really getting the best expansion of the stent? Any D-shaped stents that you're leaving behind, and so forth. So, but you asked in the good old days, that's what we did. Pretty much.
Certainly a welcome addition having
Yes.
lithotripsy, tell you that.
So, Dr. Wiley, you have a 014 wire there?
I have an 014. I have a mailman here. We already advanced the lithotripsy catheter, which has 5 emitters. And we're going to start the 300 pulses, which would be 10 cycles of 30 pulses. So what we're going to do, we're going to do low pressure inflation, go up to 4 atmospheres. We then start the lithotripsy. There you go.
See the waist right there.
Okay. Yeah, go. Yep, good. Okay, let's start it now.
From a technical perspective, it will be nice if they come out with 035. Because this is a pain sometimes.
Yeah.
If you have a tortuous iliac, getting a
So.
014.
Yeah, it's opening.
So also people have not used
It seems to be
it needs
opening
a
already.
014 or 018. I think it's an 014 and it needs a good
Then you go
prep
up to 6.
beforehand. And paying attention to, they usually recommend starting with 2 atmospheres, keeping it up there, and then going up to 4. They advise not to go beyond 6.
Go up to 6.
Correct.
And then you can see the balloon
Okay, we
expand
did it.
there.
6 and down. Okay, we did our first cycle. We then went up to 6 atmospheres. Then deflate. We're going to go again. Go up to 4.
And as we're pulsing, we see the pressure
Go.
dropping in the balloon, which means it's
So the question is how many times you can run this cycle? How many times you can
4.
run these? So,
4.
I honestly don't think there's a limit personally.
4.
We've done sometimes 6 to 8 and 1, and as long, whatever it takes, to crack that calcium. So I wouldn't be limited to only 2 or 3 or 4 runs. I mean, just do whatever you need to do.
You're always
Yeah,
just
we're
do it
actually
all the time.
going
Exactly.
to do
Yeah.
10 cycles of 30 pulses, which would be a total of 300. Hopefully that'll be enough to crack the medium and deep calcium.
It's a problem.
Okay, 6. Okay, go up to 6.
Yeah, 6
And then
atmos.
go down.
Go ahead, what's your question?
It's 2.
Yeah, thank you.
Pull it back at
This
the
is more of a peri-procedural
You mean
planning
proximal?
question.
Proximal.
You've been talking about CT
proximal
a
stent.
couple
Yeah.
Yeah,
times.
bifurcation
In
has
real
some, so
practice, especially for
we'll advance it a little more.
CLI patients or
Like that.
wounds, I want to do a diagnostic
Go up a little.
angiogram and really see those below the knee vessels.
Yes.
But when someone comes in with claudication, low ABIs, or
Go
a
ahead.
funky ultrasound to my office, is CT always enough? I know you talked about you can
I think
see
go
the
to
calcium
4,
better
stay
on
at 4.
CT, can
Make
help
sure
get
it's
you
not
out of trouble.
dropping.
Would you still do
Ready?
a diagnostic radial peripheral angiogram, when you're so used to seeing it
So-
yourself? Or because I almost feel like when I do the CT,
Better.
I'm going to end up doing another angiogram.
4.
And I'm trying to avoid redundancy, time planning, and
Opening.
obviously contrast.
Yeah.
What do
So
you think?
so claudicants, I'll do a CT because then when I
Yeah.
do go in, if I see something, I've already got a game plan. I'm not going to redo all of the angiography.
Yeah.
CLI, you're going to the lab regardless. And if your focus is below the knee, absolutely
get the
CT
middle of the
is not
calcium
great
right
for
on
below
the
the
other
knee
knee.
because the
So
amount
we're
of
going
calcium
6?
there obscures everything.
6.
So
down.
I'd separate it sort of like that, claudicant versus
It's at the
CLI,
middle of the catheter, right on the
because
knee.
I think you can get
Up with
a
that.
lot of useful information. And
Ready?
sometimes you even catch, you catch people with aortic occlusions. And if you'd have gone straight to the lab there, unless you went radial first,
That's good. Okay.
you'd
There's a
be
dot right
struggling.
there.
Go up again.
So
4.
I don't think there's,
So we done how many?
Um,
4?
yeah, I mean, it
Shouldn't
saves
be
me
the 4.
time and it helps me prepare
Definitely improve.
for
Ready?
claudicant
Yes.
patients. And then, like I said, when I go in, I don't redo all the angiography, so the contrast is low.
Do you ever do CTs on prior stent patients? When
Yeah.
you do.
Yeah, just depending on. Stents this size, you'll see just
Okay,
fine.
You'll be fine.
Yeah.
Okay.
So a practical approach is your physical examination will dictate if you have inflow or not inflow disease, as we talked in the previous talk. If you have evidence of inflow disease, I think it's very reasonable to obtain an axial scan. It will evaluate the anatomy distribution and give you bleeding risk and hostility.
Six.
For outflow disease or
And
infrainguinal
down.
disease, particularly below knee, I would not recommend. I agree with George.
Do another one.
It doesn't give you what you need
Yeah, let's
for
do the
primary
10.
revascularization.
What?
It really
Let's
doesn't.
do the
It
10
doesn't give you
cycles,
any
okay.
extra data either.
Same
So
place.
I think angiogram straight
a
for
little bit
CLI,
more.
infrainguinal is okay.
Right.
Suprainguinal, whether CLI or IC, I think you should CT scan. It's probably a very helpful contribution.
So then I would like to ask the two of you,
Right.
how do you examine your CT scans? Because what I use is Terra Recon, and I use 3D reconstruction with MPR, draw a center line through these vessels, and I evaluate these vessels everywhere in the body from head to toe.
You bet.
So how do you guys evaluate CT, or why do you make those comments
That
for CTA?
so that's exactly right. So I always start off looking axial, but then I do the curved reformat. Absolutely, this new centerline technology, depending on what scanner you use too. So we have an Aquilian 1, so we have a 320
Six.
slice because we do a lot of coronary work, and it gives you fantastic pictures. It's a very rapid scan, and we're able to use lower contrast. But when you get down to below the knee vessels and they're so calcified, it doesn't matter if you reformat or axial or whatever. It's
One more
obscured.
time.
So
One more
even
time.
when you draw a center line through it,
Yeah.
even when you look inside stent struts, which is
Yeah.
the
I didn't see
you
it.
know, double calcium, you can still draw center lines, and you can evaluate lumens. In my experience, in the head, the vertebrals, the below knee, and the small vessels, that everything is difficult at. But no, I agree completely. The gold standard, ultimate, is digital subtraction angiography below the knee with retrograde and antegrade dual injections, etc.
Yeah.
So irrespective if I'm taking my patients to the lab or not, and I know I'm going to take them to the lab, I still like to have some CT information before. It helps me map the entire procedure. It helped me beforehand, especially if you're in the OBL setting, and you need to know exactly what your next step is going to be. You're limited on the amount of time you have, and your patient's going to go home the same day. It's good to know what you're expecting. It's good to know what your plan is, and that would just makes you more efficient. And sometimes you'll be surprised. Many things you have not expected you will be seeing on that CT will change your plan completely.
Great discussion. So I
don't
think
know
when
if it's
Dr.
my
Wiley is doing that,
imagination,
we'll probably
but-
have a talk. Is that okay, Dr. Wiley? We'll just while you're working, we're going to have a
Of
talk.
course.
So
I don't know if it's my imagination, but I think it's starting to look already better. At
Oh,
least
absolutely.
the amount of the iliac, external iliac stent seems to be a little more expanded.
I'm going to take this out.
So, Dr. Wiley, can you just tell us, you had the lithotripsy balloon and then?
So we
Dr. Wiley,
did
can you hear
the
us?
10. Yeah, do you hear me?
Yeah, I can hear you guys. Go ahead.
You put it?
Yeah, let me show you what we did.
Uh-huh.
Yeah.
Go back to the last one, please.
Lithotripsy balloon.
Okay, this is our last lithotripsy balloon. I don't know if it's my imagination, but it already looked a little better expanded.
Absolutely.
And the pressure tracing went up as well. More pressure
Correct. Our systolic pressure was somewhere between 90s and 100 on the left femoral sheath. Now we're up to, 160? I don't know if you guys see the
After the
pressure
stent.
tracing. Okay. Then right after that, we put a cover stent. Can we show the next one?
So this is post lithotripsy.
This is
alone.
post lithotripsy.
And we also dilated the bifurcation of that left common
Common
iliac
iliac.
because there
Then
was
the
some
next one.
stenosis on Ibis. Yeah.
So, I'm sorry, do you think of re-ivising after the first round
Sure,
of
we
lithotripsy?
will.
No, did you guys consider?
No, we're going to do it after we stent in.
Yeah.
You know,
And what-
we're probably not going to go again with lithotripsy. We could go with another balloon, but already looked expanded, at least on Flora and Cine.
And the
and
pressure tracing.
what stent was this?
This is a BVX. This is a 80 by
Not yet. Next.
39 BVX. If you look at the pressure tracings, the systolic pressure at the level of the sheath went up from 90s to 100 to 180 right now.
Oh yeah, maybe.
So would anybody think of re-IVISing after one round of lithotripsy? What does it help in?
I mean, I think you just see
I think
what
it's
your result is
reasonable.
and decide if you're going to do anything more. Because it looked pretty good after the lithotripsy.
Correct.
Or lithoplasty.
Is there a little bit of intramural hematoma? Dr. Wiley read on the inferior aspect of the left common iliac stent, the medial aspect.
It may be. That's the reason why I think when you do something like this and you want to be aggressive, it's reasonable to use a cover stent. If I had not, I'll probably be in a little problems here. Oh, is your practice in cases like this using cover stents?
Yeah,
we
when
have
I see
the advantage of patency rate based on COBAs, but other than that, I think that there's a safety issue here, and I think it's reasonable to use cover stents in cases like this.
Oh, absolutely. What do you guys think?
Yeah, I want to sleep tonight, so yes.
Absolutely.
So the question is, we already put an 80 by 39 BVX. The question is, it looks pretty well expanded to me, whether we go with a non-compliant balloon and go up higher. What's the opinion of the panel?
We still
Steve?
have patency of the internal iliac on that side, so the covered stent is not truly occluding that internal iliac, even though it's collateralized. So we were thinking that even if it occluded, we wouldn't have a compromise because of the collaterals. But clearly, it's still patent, and so that would mean that we have some flow down from the iliac, from the external iliac to the.
And you'll be
common.
trading calf claudication for buttock claudication, yeah?
Right.
Actually, that looks pretty good.
We looked at the collaterals on the other side and the robust collaterals on the
Should we IVIS
the
it
right
before
side.
we proceed?
Yeah. Are you guys interested in Ibis?
Yes.
Sure.
Makes a lot of sense.
Sure.
Let's go.
Okay, let's have
Give
the
me a,
change.
So, Dr. Wiley, looks like you went in again with was it an ATO balloon by any chance?
Oscar, so what we did is that we did intravascular ultrasound, and I'll show it to you.
Yep.
And based on what we saw, we decided to go up with a non-compliant balloon, high pressure. Then we did a second Ibis, and it actually looks much better.
What size is
Can
the
you
non-compliant?
discuss it, please?
What size is
8
the non-compliant balloon?
8 by 20.
8 by 20.
What kind?
Yeah, as you can see in this, can you see the
it's a
screen?
Mustang. I wanted to use a Dorado, but I only have a 40. I don't want to use a 40 when the size of the cover stent is shorter than that.
Okay.
So we went high pressure with the Mustang. And I'll show you the Ibis results now.
Yeah, Ibis on screen. Okay, so this, as you can see, this is the Ibis on the screen. This is the covered stent. You can't really see the media and vessels outside, but as you can see, this is now like 7.8 by 7.8, nicely round and expanded. That's our final results.
Beautiful.
Very nice.
Alrighty. Any questions from the panel or from the audience?
And the internal iliac is still open, so.
Yeah, we're.
So just for
happy
the
with
panel,
that.
say after you do the second run of Ibis and you see that the stent's not well expanded, is there a criteria when we stop and say, let me not get too greedy because eccentric calcification, perforation is a risk?
We'll check later.
Yeah, I mean, I think
Can you call it?
the
Yeah, I gotta go.
hemodynamics were one indicator that things were
Talk to you
improved,
later.
and so
Yeah.
how much more you want to improve them is kind of a game time decision and up to whoever's doing the procedure. I mean, this looks great. At the end, it took a lot of work and a lot of high pressure and a lot probably more than low risk, but it turned out nice.
Thanks a lot, Dr. Wiley. Appreciate it. Thank you.
My pleasure. No, thank you guys.